Okay, so firstly, thank you, CPDme, for hosting tonight. It's a real pleasure to be able to obviously present to such a wide range of the audience. Tonight we're going to cover aortic dissection, a bit of an overview, a bit about how the aortic dissection is currently kind of managed in the NHS. We're then going to go into a bit of pre-hospital guidance, and then finally finish with a patient story. So without further ado, I'm going to introduce our first speaker, and that's Catherine, to take us through the first stage.
Thanks, Simon, and thanks, Dawn, for such a warm welcome to the CPD membership this evening. We're delighted to be here to reach out and speak to so many members from your community. In fact, I think it was one of your members who joined the charity launch at the end of March and reached out on Twitter to say it would be great for the charity to come along and run a session. So it was something that one of your active participants reached out to actually join the dots and make this happen. So we're delighted to be here, and we've had a great discussion with the team at CPDme, and this is going to be the first of a series of sessions about aortic dissection. And as Simon has touched on, the focus this evening is really about pre-hospital care and early recognition, and the clinical guidance really to support you in the detection of this detectable killer. And in time we'll run a series of educational events with the CPD community, touching on all aspects of the patient pathway. So we're delighted to be here and to be educating, a cheeky bit of learning, as you said yourself. It's brilliant. We're really delighted to be here. So Simon's kind of driving for us tonight, so we'll skip on to the next slide. And really, I think just to set a little bit of the context about aortic dissection, 2,000 people in the UK every year at the moment lose their life unnecessarily to this condition, which is actually a detectable condition, hence the detectable killer. And we know that the number of people who are projected to have an aortic dissection is actually set to double by 2050. And so for us, if the landscape in the UK remains the same, we can forecast that 4,000 people will lose their life to this condition unnecessarily. I think it's a really, really important fact to understand that when patients who have an aortic dissection are diagnosed and treated on time, they have a survival rate of over 80%. Which I'm not sure how well that is understood or known, but it's such an important fact. And I think that's why it makes it so incredibly difficult to accept and believe that still over 50% of patients are misdiagnosed of this condition, and 33% of those patients are actively treated for the wrong condition. So we understand that early detection is really essential for this time critical killer, to give every patient their chance and a good chance for survival. And if we can skip through to the next slide, I think we've also understood really that aortic dissection, it's not a condition that discriminates by age, that almost 50% of patients are actually under the age of 60. And also 11% of deaths in pregnancy that are due to cardiovascular causes are due to aortic dissection. And we know that 70% of cases are caused by high blood pressure and the aging of the aorta, and 30% are due to other causes that may be due to inherited and genetic conditions. So there's definitely a few myths to bust around aortic dissection, but from, I suppose, a very personal view, and Simon, if we can skip through to the next slide, I hadn't heard of aortic dissection until 6 years ago, when a catastrophe really struck our family. And then when I learnt more about this condition, I was really surprised that the same number of people who die from this condition relate to that of those who die from conditions like skin cancer or a blood clot on the lung. And so I couldn't understand how I had never heard about it and why I didn't recognize even the name. I had never heard of the condition aortic dissection. And it touched our family. So my dad, who you can see in the picture there, Tim Fleming is his name, and he was a very fit and energetic, life-loving 69-year-old man. He was a husband, a father, a grandfather, and fully engaged and very active in life. And otherwise, and to our knowledge, he was fit and healthy. He became suddenly very, very unwell, and he was admitted to A&E, and he displayed all of the classic symptoms of an aortic dissection. And after 18 hours of assessment and extensive pain relief, my dad was discharged with a misdiagnosis of gastritis. And that misdiagnosis, I suppose, is what really led to aortic dissection claiming my father's life. And I firmly believe that he should and that he could be with us today. There were so many opportunities that were missed in saving Dad's life, and the family were really left and are still left with all those questions of what if, what if the team were trained to suspect and detect aortic dissection, even on the classical symptoms. What if there was a really clear treatment pathway that they could have followed and led them through a diagnostic path and to a treatment pathway? But sadly, that wasn't the case for my dad. And sadly, also, that wasn't the case for the team who cared for my dad. That pathway wasn't there. And we spoke to the hospital because we wanted to understand from the team a bit more about the condition. And we were told that aortic dissection is a condition that isn't often diagnosed, and that even when it is, it's very rare for a patient to survive. And it was also explained to us that it's a condition that doesn't run in families. And so for us, really, we felt that, sadly, it was Dad's fate, that maybe it was just one of those conditions that nothing could be done. And then 7 days later, my dad's sister, my aunt, was struck by an aortic dissection. We were in turmoil already as a family. It was the day after my father's funeral. And we failed to tell the emergency team that her younger brother had just suffered and lost his life indeed from an aortic dissection. So it was really down to the quick thinking of the team to think about the diagnosis and to suspect it. And they diagnosed quickly through a CT scan that my aunt was having an aortic dissection, and they transferred her to a hospital where an experienced surgeon was able to give her the life-saving surgery that she needed. And her life was saved. And for us, very quickly, we understood that aortic dissection actually is a detectable and a treatable and a survivable condition. My aunt was 10 years older than my father, had lots of other complications. And for us, it was just a complete contrast of what can happen to patients. And it felt a little bit unfair, I suppose, or extremely unfair that, it can be left down to chance. So we started to do a little bit of research, and it became quite clear to us that there wasn't standardized pathways or policies or guidelines that could protect patients from this condition. And so we started a petition online.org to see if we could make a change as a family. I think anybody who's struck by grief probably reaches in to try and do something, whether that's either fundraising or make a change. And for us, we started this petition. And so for the last few years, we have been involved in raising awareness and education around aortic dissection, really wanting to change the odds, and more importantly, not leaving it down to chance for other families. We wanted to change that, and to date, over 7,000 families, bereaved family members and patients have signed to support this petition for change. And if we move on to the next slide, Simon, we really believe that there can be a different future for all patients, and there should be a different future for all patients and their family. We know that this is a preventable condition, and that through improved diagnosis and improved screening of patients and their relatives and improved blood pressure control, there can be a much more proactive patient pathway and a controlled patient pathway. And then for those patients who have an acute aortic dissection and are in an emergency setting, with that improved diagnostics and pathways, we know there can be very different outcomes for those patients. So we know that timely diagnosis will save lives. This really is a condition where time matters, and Graham will talk more about the detail of the condition itself. But half of the patients who have an aortic dissection don't even reach hospital. So we know that the importance of proactive genetic screening has got a big role to play to actually avoid the emergency situation at all, that patients will know this is a condition that they have and can reach out for proactive treatment. And we know that a number of lives can be saved where patients have got a speedy diagnosis, a speedy transfer, and access to the life-saving surgery that they need. And we know that a huge number of patients die without that diagnosis at all, and that is something that through education we hope to change, and everyone here has got a role to play in that, whether it's through education, taking that education and making that education count. So thank you, Simon. So at the beginning of the lockdown itself, Graham and I had a conversation about changing the landscape in the UK. And to that point, there wasn't a charity that existed for this condition. And that was something, a gap, I suppose, that we really believed and felt that we could make a change and make a real difference, and agreed that that was something that we really wanted to make a mission and commit to. And we approached Pauline Latham, who agreed to become our third trustee. And Pauline sadly lost her son, Ben, who was only 44 years of age, a young man, a family of 3 children with his life ahead of him. Pauline really was committed to this mission too, into making a difference and starting the charity, the Aortic Dissection Charitable Trust. And the charity itself focuses around 3 key pillars. So education plays a really, really important role across the entire pathway, educating medical professionals and patients themselves as well. We're very keen as well to play a role in promoting and funding medical research into the detection and prevention and treatment of aortic dissection. And we know that policy change has got a significant role to play. So it feels sometimes like it's a bit of a dad's army approach, bottom up education and change, but we know all the governance and policy structures that can support that change from happening, and then looking to the future into the world of research. We hope to make a difference. And I think for all of the team that are involved, and the patients that you'll hear from Joanne today, and Bob Harris is also an advocate of the charity, it's really important that their experience counts, and counts for education. And I think especially for those who have lost their life to this condition, to make that loss meaningful. We certainly don't want that life to be lost in vain. If it can count for something, and count for change, then I think it really gives some purpose. We know that a number of mistakes that we hear about in aortic dissection, and I'm sure there's lots of people in the audience tonight who've heard lots of stories. I think it's it's learning from those mistakes, because it is they are preventable. And I think it's really important for change to happen. It's something that we all need to be part of. Collaboration really matters. And I suppose today for us, that collaboration really starts with, the community at CPDme. We're really keen to share our experience, to share our expertise, and also to hear from you. We'll have a conversation, I'm sure, at the end of the session, and to share your experiences. And equally, it doesn't have to be a one-time thing. So if there are members in the audience tonight who want to run further education within your teams or beyond, reach out to the charity. We're really keen to help and support and educate, and support change in any way that we can. So stay involved with the charity, enjoy the session tonight. And we look forward to a discussion at the end. So I'll hand over to Graham Cooper, who is our trustee, and he'll take you through the pathophysiology of aortic dissection.
Thank you, Catherine, and good evening, everyone. Really good to be able to join you this evening. Simon, could we move the slide on, please? Thank you. As I'm sure you all know, the aorta is the major artery in the body. It's what supplies blood to all our organs and our limbs. And it arises from the heart, and the first part runs up behind your breastbone, and then it arches over into the back and runs down next to your backbone. And the wall of the aorta has three layers. They're termed the intima, the media, and the adventitia. And they're designed to withstand the stress put upon the wall of the aorta when the heart beats. And when an aortic dissection occurs when you get a tear in the intima, so on the inner part of the aortic wall, that allows blood to enter the wall of the aorta. And once blood's in the wall of the aorta, with every contraction of the heart, that blood is forced along the length of the aorta, so that you end up with a situation where you have two channels through which the blood flows in the aorta: the true lumen, which it would normally flow through, and the false lumen, the channel created by this aortic dissection. And that has two potentially serious consequences. The first is that the wall of the false lumen is, by definition, weaker than it should be, and therefore it may burst, with usually fatal results. And secondly, as illustrated in the top of this schematic here, it may interrupt the blood supply to branches of the aorta, so that can cause symptoms such as a stroke or an ischemic leg, or even a heart attack. Slide, please, Simon. And this act of interrupting the blood supply to a branch of the aorta is called branch vessel occlusion, and it is usually a dynamic affair, so it comes and it goes. It's due to the pressure in the false lumen compressing the true lumen temporarily, so no blood flows down that branch, but then that gets relieved, and that's called true lumen collapse, and it is responsible for about 90% of branch vessel occlusion, but it can be a permanent fixed occlusion as well, in which case obviously the symptoms that you might get for that are fixed and permanent, whereas with a true lumen, a dynamic occlusion, people might exhibit signs that then resolve, but then may come back if the true lumen collapse returns. Slide, please, Simon. So there's several ways of classifying aortic dissection, but the simplest and most practical is the Stanford classification, which classifies it according to where the aortic dissection starts. So if it starts in the ascending aorta behind your breastbone, it's called a type A. And if it starts in the descending aorta behind your backbone, it's called a type B. And about 70% of acute aortic dissections are type A, the remaining 30% are type B. Slide, please, Simon. And as Catherine's mentioned, there's about 4,000 acute dissections per year in the UK, and as I say, 71% of these are A, and about type A, and about half of those people will die before reaching hospital, which means that in terms of treatment, there's just about 52% of those having an type A aortic dissection have the potential to have their lives saved. So that's about 1,500 patients a year in the UK, but only about 1,000 of them undergo surgery. So there's around about 500 people a year who reach hospital with their aortic dissection, but do not undergo surgery to save their life. And the reason they don't undergo surgery is almost always because their aortic dissection is misdiagnosed. Slide, please, Simon. So we know from the medical literature that a diagnosis of aortic dissection is considered in less than half of patients who present with one, and about a third of patients are actively treated for the wrong diagnosis. Slide, please, Simon. And so why is this? Well, there's some misconceptions about aortic dissection. One is that it is rare. Second, that patients with aortic dissection are really sick. Well, they are really sick. They have a potential fatal condition, but they may not appear really sick. And that differential blood pressure in the arms is an important diagnostic sign. And I'm just going to quickly run through those. Simon, if we can move on to the next slide. So aortic dissection is fairly rare. 6 per 100,000. The incidence is 6 per 100,000 per year. So that gives us 4,000 cases per year in the UK, which is about the same as the number of patients who are diagnosed with a new brain cancer each year. And within 30 days of onset, about 2,500 people will be dead, which is greater than the number of people who die from a road traffic accident. It's about the same number who die from pulmonary embolism each year. It's about the same number who die from skin cancer each year. Slide, please, Simon. And although overall the incidence is 6 per 100,000, it's an age-related disease, so the incidence is higher the older you are. So in 65 to 74-year-old age group, the incidence is actually 34 per 100,000 people. So that compares to an incidence of myocardial infarction of 660 per 100,000. So that means in this age group, for every 20 people who present to an emergency department with a myocardial infarction, there will be one who presents with an aortic dissection. And in this age group, that is about the same incidence as the ruptured abdominal aortic aneurysm. Slide, please, Simon. So the third misconception is that patients with aortic, second is that patients with aortic dissection are really sick. Well, a proportion are. So about 15% of patients will be hypertensive, be shocked, have signs of cardiac tamponade or congestive cardiac failure, but only about 15%, about 85% will show no abnormal signs. And the differential blood pressure in the arms is a really important sign because it's extremely specific. So if you look at the right-hand side of this top line of this graphic, it shows that the specificity of differential blood pressure in the arms is almost 100%. That means if someone presenting to ED does have differential blood pressure in the arms, they are very likely to have an aortic dissection, but its sensitivity is really poor, maybe 20%. So that means that less than 20% of patients who present with an aortic dissection actually have differential blood pressure in the arms. So the absence of differential blood pressure in the arms does not rule out aortic dissection. Slide, please, Simon. And then briefly, how's it treated? Well, type A aortic dissection requires an immediate emergency cardiac surgery, and around about 20% of patients will die as a result of that operation. So 80% will survive. And if you don't operate on them, about 10% of patients will be alive without an operation at a year after the procedure. The type B dissection is less fatal than type A, and most patients can be treated with just blood pressure control and pain relief. But if they have complications, so they have persistent pain, the dissection leaks, or they have ischemia of the limbs, excuse me, then the preferred treatment is an endovascular stent placed in through a femoral artery, and that's very effective at saving lives, but about 10% of people will not survive that procedure. Slide, please, Simon. And so yes, so we briefly touched on this: medical therapy, close observation, blood pressure control, and analgesia. And then the complications of a type B dissection that lead to intervention listed there: malperfusion, so ischemic limbs, persistent pain, rupture, or uncontrollable blood pressure. And endovascular stenting is the preferred treatment for that. Slide, please, Simon. And Simon, it's now all yours. Simon's going to tell you a bit about how the importance of pre-hospital diagnosis and the really vital role that pre-hospital clinicians can have in the diagnosis of aortic dissection. Simon.
Thank you, Graham. So yeah, as Graham said, we're going to cover, it's going to have a pre-hospital focus, but there's going to be a lot about kind of the history and the importance of taking a really good history. So one of the first bits I want to discuss is about the risk factors. So obviously, this is not an exhaustive list, but these are key kind of findings in an aortic dissection patient. So a history of hypertension. Obviously, we could arguably say that many of our patients will have a history of hypertension, but definitely those with poorly managed or maybe undiagnosed previously hypertension, that would be a big risk factor. Obviously, if they've already got an aneurysm as well, so obviously, as Graham has kind of touched on, that it's going to have that weakening of the wall. So potentially that obviously then is going to lead to a dissection. If they've got a family history of aortic disease, and I think Catherine's story really kind of highlights obviously not only the father side, but also with her aunt as well, that actually that close link and that being a week apart as well is almost unheard of, but that kind of close family link is really a big part of a history. Also, if they've got Marfan's or a connective tissue disorder, so patients with Marfan's are statistically much more likely to have a dissection. So that's something, if a patient comes to you with chest pain, back pain, and they obviously share with you that they've got Marfan's or similar condition, then really that should be a red flag. Pregnancy, so we did touch upon it a little bit earlier, but obviously about 11% of pregnancy-related deaths can be attributed to aortic dissection. So again, if you've got someone who's heavily pregnant and they've, got an acute pain, then be careful not to rule it out too quickly. And then, as we touched upon as well, there's more and more research being done into genetic factors. So again, not an exhaustive list, but stuff that if they're coming up in your history to really to tune into. So in terms of associated symptoms, so again, this is not an exhaustive list, but we've got pain is the number one associated symptom. So commonly in the chest, back, abdomen, and neck, but obviously it can also occur in like the flanks and areas like that, depending on where the dissection is. We'll talk a little bit about the pain characteristics in a minute, but the pain, just be aware, pain is the number one symptom. History of collapse, very much obviously related to pre-hospital kind of initial presentation. We'll go to a lot of calls that are, query collapse, and obviously that'll be part of your assessment to really kind of establish what was the cause of this collapse. A weakness in any of the limbs or numbness. So as kind of Graham alluded to earlier, that obviously the dissection can have a kind of quite severe effect on the limbs, so it can present like a stroke, and I think probably a lot of the misdiagnoses have almost been thrown off because of maybe stroke-like symptoms. And then often with these patients, there's a kind of a state of agitation or restlessness. And having been to a few of these patients myself, I can only really describe it as that they seem very uneasy quite a lot of the time. They can't sit comfortable, and that's quite apparent. So just alluding to more about the pain. So pain is often maximum in seconds. So I kind of make the kind of general speech of, it's not just a sudden onset of chest pain, because quite often we have patients describe this sudden onset of chest pain, and when you investigate it, it turns out it's about 3 days ago. But actually, this is a real rapid onset. They've gone from nothing to 10 out of 10 in a matter of seconds, and that's that real thunderclap, like come out of nowhere pain. So that is heavily associated with aortic dissection. This can catch people out, so it can be transient, it can migrate. So, when we get there as pre-hospital clinicians, it might be that actually it starts as a chest pain, but by the time we've treated and got them into the ED, it may actually now be chest and abdo pain, or maybe chest and back pain. So that will just be something to keep in mind, and obviously, especially when you're handing over that information as well. And then it can be described as ripping, tearing, stabbing, or sharp. So again, these are key kind of words that should probably set your kind of senses tingling a little bit, but obviously that's not an exhaustive list. So I mean, I've actually had one patient described it as an abdominal ache. So it's a really hard condition to really put a title or a description onto. Hence why I think you've just got to be really kind of alert and have it as a differential for quite a lot of our presentations. In terms of the physical exam, so there may be signs of a cardiovascular compromise or pulse deficit. Obviously, what we may find as the patient kind of starts to deteriorate, you might initially have a pulse increase where they compensate, and then that obviously might start to decline. They might then turn bradycardic, but it obviously may not present with every patient like that. We've kind of touched on it again, but the neurological findings, so not just maybe weakness in limbs, but also elements like acute confusion. Obviously, depending on the condition of the patient, or when you arrive, it may be that there's a state of hypoperfusion, so they may become acutely confused. And when you're thinking about your differentials, you may not think, well, actually it could be a UTI or another condition, but actually it's about having what actually is the fundamental cause of this confusion. As Graham's touched upon, obviously potentially a BP differential, but obviously if there isn't a BP differential, then you still can't exclude dissection, as Graham alluded to earlier. And then a new murmur as well, but obviously in the pre-hospital setting, it's quite hard to diagnose a new murmur. Quite often we won't have the existing records to know if it's new or it's an existing, but obviously it's a finding of note. In terms of diagnostic, obviously in the pre-hospital setting, we are going to be fairly limited. So obviously we can do things like ECGs, X-rays will be done in hospital, blood analysis in hospital, ultrasound. But obviously the warning of this slide is actually they can all be normal, and what this patient needs is a very urgent CT, so an aortic CT, and that is, I mean, from the images to the right hand side here, you can actually see where when Graham was talking about that true lumen and false lumen, the second picture actually identifies that really well, and that's what the CT kind of brings to this diagnosis. So talking about kind of what we can do for these patients in the pre-hospital setting. So one tool that is endorsed by JAL-CALC, and it's in the vascular emergencies guidelines that were created in 2019, is the ADDRS score. So it's not a particularly catchy title, but it's the Aortic Dissection Detection Risk Score, hence probably why they abbreviated it. And obviously what we can do as pre-hospital clinicians is part of our initial assessment is we actually can correlate this score within a few seconds. So it's quite simple really. So each column you can obviously score a maximum of 1 point in. So even if you had Marfan syndrome and a previous aneurysm, that's still only be 1 point, so you score a maximum of 3 points. If you're scoring a 2 or 3, essentially that would be a recommendation to have a CT. So what I'd like to see as pre-hospital clinicians is actually, as we go into the ED department, using this tool as a part of the handover to really emphasize this need for the CT. So that is something that we can all take out in our practice. As shown on the left hand side there, it's available on MD-CALC, which is a really good app for assessments and tools, or it's on the JAL-CALC app as well. So a little bit about pre-hospital management now. So obviously just make sure we're doing a full assessment, not to miss anything out. So a full ABCDE assessment. As I touched upon, make sure we're doing that ADDRS score just to really kind of underpin your thought process. Minimize the time on scene. So obviously the urgency of these getting the patient to the CT and getting to surgical table is really important. So for about every hour that goes past, mortality increases between 1% and 2%. So obviously, if you imagine, in the pressures of winter of long delays, that can build up very, very easily. And then ensure effective analgesia. So the analgesia is not only to obviously control the pain, but what we're also looking to do is kind of reduce the sympathetic nervous response. So what we want to do is keep that heart rate nice and low. Try not to kind of agitate the patient anymore, because obviously in an agitated state, the pressure on the aorta will increase because the heart rate and elements like that may increase. So that potentially, if that is a tear, it could cause further damage. So we want to try and keep them calm, and that's a big part of that will be the pain relief you can offer. So to continue with management, so obviously, especially with your kind of patient that's presenting with shock, pre-alert the patient obviously to your emergency department. Make sure that we're doing a really good handover, and as I said, I would include the ADDRS score. And if the team at the ED aren't sure that, just explain. That's absolutely fine. There's something that say it can be easily calculated in a matter of seconds. One thing I would say with the handover is be really, really confident in kind of passing across your feelings. So, and I've got on here that if you can place emphasis on that presentation of when you first walked into the room, and I think as pre-hospital clinicians we do it really well. We have that gut feeling of actually there's something not right with this patient. So really get across your message of how that patient was on your arrival, because as Graham touched upon, actually they may not always present as the sickest patients. Sometimes there's just something not quite right about their story or their presentation. And if you can almost hand that feeling over to the ED clinicians, what you're giving them is the truest presentation of that patient. Because time we've given them pain relief, and made them a bit more comfortable, reassured them, actually they may present in a different manner to what we first found them. We probably find that with a lot of our patients, but that's something that will enhance the potential pathway that sets that patient on for the rest of their care in the hospital. So what we're going to do now, I'm going to hand over to Joanne, who is going to share her very personal story of aortic dissection. So Joanne, over to you.
Hi everyone. So my name's Joanne. I'm 48 and I live in Cheshire with my husband and son. First, a little bit of my medical history. I was diagnosed at 13 with Marfan syndrome. At the age of 35, I had an aortic root replacement with a mitral valve repair. Now, the aortic root replacement was due to an aneurysm, so that's obviously worth knowing. So in 2012, when I was 39, I had a type B dissection. This is my story of the dissection. It was early on a Wednesday morning. I woke up, turned over, and immediately had a severe pain. The pain started in my chest and it was followed by a ripping sensation. It went from the chest down to the bottom right of my body. So it was sort of right across the body. It was just like a zip. That's the feeling. It was like a zip opening from top to bottom. That's what I told paramedics when they came. And it was followed by intense back pain and a very clammy feeling. I'd never called for an ambulance before in my life, but somehow I just knew immediately that I really needed help. I needed one. I felt so poorly, far more ill than I'd ever felt in my life before. And it felt like I was dying. That's the only way I can explain it. My husband dialed 999 and the paramedics arrived really quickly. They couldn't find any sign of a problem with my heart. And reassuringly to me at the time, they weren't overly worried. But because of my medical history, they took me to A&E, whereupon I was given a chest x-ray and an ECG. I was also given plenty of pain relief. I had morphine and intravenous paracetamol. So of course, the pain became much better. After about 2 hours, they sent me home. They said it was just undiagnosed abdominal pain and take paracetamol every 4 hours. I did. I went home still feeling awful. In fact, my sister was in the car with me and she said, we really wanted to turn back because you just looked so ill still. But I spent the next 48 hours in absolute agony, unable to sleep or get comfortable in any position. On the Friday morning, my dad came to see me and begged me to go and see my GP. you feel like you don't want to bother anybody, because I'd already been to A&E and they'd said I was fine. But I did. I went to see my GP. He immediately sent me to a different hospital. I don't know what he suspected. I was given a CT scan, which revealed a type B dissection. I then spent 3 weeks in hospital in Liverpool Heart and Chest Hospital, actually, and they got my blood pressure under control. And then just recently, in fact, last year, I had the whole aorta replaced with a Dacron graft. And I am now, thankfully, fit and well and here to share my story. Thank you for listening.
Thank you, Joanne. I mean, it's nice to be able to obviously share that, you know, some of the patient stories, I think, and really hone and bring back some of the experience and make it really human. So thank you for that. So one of the bits just before we finish is what I want to finish on is, so what can, you know, you as the audience member do in terms of your team? So Catherine alluded to it a little bit earlier, but these are 4 simple steps that pretty much all of us can take back to our practice. So firstly, just evaluate your performance. You know, how confident are you at recognizing a dissection? How confident are your team? Obviously you're here today because there's an interest in that. It may be because actually you feel like you're underconfident, or you feel like that you could take this further. So that's brilliant. Enhance your understanding. So again, it's brilliant that you're here with us tonight, but also think about, you know, could we do this for our teams? Educate, so students, colleagues, anyone we come into contact with in our workplace that's relevant to, you know, we also do the general public as well to have a better understanding, is, you know, getting the message out there. And that's what a big part of the charity is. It's, as Catherine said, when she first heard about it, you know, no one in the family had a clue what dissection was. And then only a week later, obviously her aunt suffering from it as well. And then finally, stay connected. So obviously there's lots of resources through the charity. There's a website you can contact. And, you know, if you want to get involved, then just drop us a message, drop us an email, and we'd love to hear from you. So yeah, aortic dissection, the detectable killer. Obviously the key theme is detection will save lives, and I can't emphasize that enough. You know, of them patients that we shared with earlier about the 1,500 not even making it to hospital, they're the ones that we can really make a difference to. There are contact details, so as I said, feel free to get in contact. And then finally, we're happy to take any and all questions you've got. So I'll pass it back to Dawn.